About AKI, functional and structural phenotyping of CKDs is something which is evolving again, and the management options, how this diagnosis correlates with our important management decisions in these patients. So when we look at the spectrum of kidney health in a patient with cirrhosis, we can see that in a patient with cirrhosis, the patient may have, when you see a patient with acute kidney injury, the background kidneys may be normal, so they may be normal kidneys. You may be dealing with a patient who has acute kidney disease, that is, the patient is having, the patient, can you just see? It's changing. Please move. Why is it moving? नहीं आगे नहीं जाए पीछे. Yeah. So chronic kidney disease. So over here we see that acute kidney disease is a subacute renal dysfunction where the GFR reduction below 35% of the normal, or there is a prolonged AKI which persists for at least 90 days duration. Beyond 90 days, and if the GFR decrease is persistent, it becomes chronic kidney disease. And what we see in these patients is there is a clear overlap. So a patient may have acute kidney injury on a background acute kidney disease or chronic kidney disease, or the patient may be having AKD, which can go to CKD, or a patient may have acute kidney disease on a chronic kidney disease. So it is a complex spectrum that we can see in any patient. So how do we understand, therefore? Presentation, present. So this is how we can see over here. Can we have a point? So we have normal kidney disease, acute kidney. When the patient gets AKI, depending upon the severity and the duration of AKI, the patient may have a complete return of the renal functions to normal, or the patient may continue to have some form of renal inflammation, acute kidney disease, going to chronic kidney disease. And again, these chronic kidney disease patients can progress to different stages of chronic kidney disease in these patients. So coming to the pathophysiologic basis, so this is another very important cartoon for us to understand. In a patient with cirrhosis, we may have risk factors for both AKI and CKD. So there may be risk factors for acute kidney injury, for instance, in patients with decompensated cirrhosis. At the same time, if you are having a patient of decompensated cirrhosis who has an etiology, for instance, the NAFLD or the MASLD, we see that the risk factors like diabetes, hypertension can predispose to also the underlying chronic kidney disease. And when we've shown that acute kidney injury can really go on to chronic kidney disease, so therefore the patients who get AKI can again go on to the development of chronic kidney disease, and CKD again predispose these patients to develop repeated episodes of AKI. So this is how it evolves. So we have to understand that any patient with decompensated cirrhosis may have risk factors for both AKI and CKD. And again, AKI and CKD may itself lead to the development of more episodes of AKI in a CKD patient. And also AKI patients can progress to CKD. And why does this happen? There is a concept of renal reserve. So this is very important, again, when we are measuring the GFR in these patients. This is in the basal state. However, when you look at the GFR, that is the renal functional reserve, if you do a protein loading test of amino acids, we see that there is an increase in the GFR from the baseline eGFR. Now, this increase in the GFR is what is the renal functional reserve. So what is interesting over here to understand is that with each episode of AKI, there is some loss of renal mass or nephron mass. It may or may not be reflected in the loss of the renal functional reserve. However, with time, with increasing episodes of AKI, there is increase in the losses in these nephrons, and these patients may get again predisposed to repeated episodes of AKI after the same insult. So if a patient is on diuretics, the same patients get predisposed to develop AKI who has developed AKI in the past and has a poor renal functional reserve. And this is what we showed in this old study from our group, where we showed that in patients with decompensated cirrhosis, this was a cohort of 500 patients. The first half was done by Avinash, and the second half we had done prospectively over here. So what we showed here was that cystatin C was recognized as an important biomarker. And along with, so we developed a score called as MEL cystatin, where we incorporated the components of the MEL score and included cystatin C. And we could see that when you measure cystatin C in these patients at baseline, you can predict which patients can develop future episodes of AKI. And the patients who were developing AKI, this itself predisposed to further development of AKI episodes. Subsequently, we took this work forward and we showed that irrespective of the number of AKI episodes, it is the level of cystatin C as well. So cystatin C above 2 at baseline was predicting the development of chronic kidney disease. And this was a large cohort of cirrhotics, 818 cirrhotics. We used the eGFR equation using the MDRD6 equation of assessment, because MDRD6 equation also incorporates urea and albumin, which are extremely important while measuring the GFR and understanding the renal function in patients with cirrhosis. So we showed that apart from the CKD, the factors, the liver disease itself. So the severity of the liver disease, as was governed by the MEL score, cystatin C, the number of AKI episodes. And if you're seeing a patient and he had an AKI episode in the last 3 months, all these factors led to future development of CKD, which happened in almost 1/3 of these patients. So again, we can come back to this story that AKI and CKD is an integrated clinical syndrome. And what happens is, we talked about the renal mass and the nephron number reduction with AKI, but at the level of the renal tubules, there are a lot of factors again which are interplaying. There is vascular insufficiency, there is cell cycle disruption and maladaptive repair that we need to understand. So what is an adaptive repair and what is a maladaptive repair? So whenever there is AKI, there is insult to the renal tubules. There is release of the tubule epithelial cells, and this happens only when the AKI is severe and it causing a significant damage to the renal tubules. It will not happen in milder forms of AKI. So these renal tubule epithelial cells will draw. There is influx of the neutrophils in the renal tubules population. There is ferroptosis, oxidative stress, and this is particularly noted in the context of critically ill patients or severe sepsis or shock. There is significant damage to the renal tubules. So what happens is, when the patient is recovering from this AKI, there can be two forms of repair. There is an adaptive repair where the macrophage infiltration is causing the resolution of the inflammation in the renal tubules, and the patient may have the return of the renal functions to normal. But they can also be a maladaptive repair. The maladaptive repair is, there is a persistence of the immune infiltration in the renal tubules, there is vascular insufficiency, there is cell cycle disruption, and subsequently these patients may slowly go on to the development of progressive scarring and fibrosis at the level of the renal tubules. So identification of the duration of kidney dysfunction is extremely important, and the patient may slowly be going into acute kidney disease. So never ignore your patients of cirrhosis. That is why we have to look at the baseline serum creatinine. We need to look at the urea. If possible, we should be doing cystatin C and also using the GFR equation by some assessment to understand what are we dealing with. Is it a normal renal function? And this is particularly seen in advanced cirrhotics, where your creatinine becomes non-reliable. Not for every cirrhotic, but in the context of advanced decompensated cirrhosis, particularly in patients with refractory ascites. Now, diagnosing CKD, as we already discussed, One is to see the estimated GFR. The best or the gold standard is the measured GFR equations. So the measured GFR equation is the iothalamate equation, the inulin clearance methods, but all these are very cumbersome. They're not practical. They are not routinely available. It requires nuclear medicine facility. And many centers do not have it. So most of us are using the estimated GFR equations. We can use any of these equations. And the other surrogate methods which can tell us about the presence of normal kidneys or the underlying chronic kidney disease, which should be made a part of the diagnostic workup for all patients with cirrhosis, is a urine analysis. A urine analysis which shows some microalbuminuria, proteinuria is something which will lead, which may precede the changes in the renal functional loss. So urine microscopy can precede these changes, should be used. Imaging is very important. And obviously, a kidney biopsy is the gold standard. But how often can we do a kidney biopsy for patients with cirrhosis? Therefore, we need these non-invasive methods. So let's look at the data of kidney biopsies, which has been there. Very few studies, and mostly the studies have come from French centers. And this was an important study where they had biopsies, 65 patients. And these patients, 50% of these patients had an abnormal urine microscopy with the sediment. They had 51% had proteinuria, 58% had hematuria. And we know in patients with cirrhosis, hematuria usually correlates with either, if you look at the dysmorphic RBCs, you may pick up a lot of these patients having IgA nephropathy. So that is the most common nephropathy that is associated. So if you biopsy these patients, what is interesting here is 70% almost had glomerular injury. But what I wanted to highlight here is the 94% of these patients had tubulointerstitial damage. So the damage was at the level of tubular interstitium. And many of us would have seen that even when we are seeing patients with diabetes associated with CKD in patients with cirrhosis, many a times it does not correlate with your glycemic control. Many of these patients may have normal fundus examination, absence of retinopathy. So it is something, again, the pathophysiology of diabetes and CKD in these patients with decompensated cirrhosis may have something not at the level of glomerulus, but at the level of tubular interstitium. And this is where we should be working on and finding out these things. This was another study here again, just to highlight that even if you're biopsying these patients, so this is another interesting, but we didn't think about it. And this is the concept where we're thinking that HRS, CKD, which we say is commonly meeting the criteria of HRS CKD, particularly in patients with refractory ascites. They may also manifest some changes in urine microscopy, but you see here the normal kidney biopsies. So whether the biopsy was not representative versus the patients that we're dealing with is having some other form of renal injury or urine microscopy, which is showing proteinuria. So this is again very important for us to know that HRS CKD even may still be functional and may not require a simultaneous liver kidney transplant. So this is another interesting modality. We do not look into the ultrasound, which we feel is not, but a lot of things on the ultrasound of the kidneys can tell us whether we're dealing with significant kidney dysfunction or not. So hydronephrosis, presence of renal stones, and very often you will see this in patients with metabolic dysfunction associated fatty liver disease patients. The kidneys may be atrophied. The size is small, which we pick up as CKD, even though they may have normal urine microscopy and normal kidney function test. There is increased echogenicity of cortex. Sometimes that is reported. Thinning out of parenchyma, loss of distinction between the cortex and medulla. And again, renal cysts. Renal cyst can be seen with prolonged renal injury, and this again can be a subtle sign of somebody having something going on into the kidneys and the loss of the kidney health in these patients. The Doppler can pick up the renal resistive indices in these patients with CKD is usually higher than 0.7. And again, ultrasound elastography, which we can look at in our patients, like we have the FibroScan so looking at the texture and looking at the elastography, particularly even with the endoscopic ultrasound, can be something which can be looked forward in these patients. And this is as a group, we looked at the which equation should be good enough in patients with cirrhosis, because whatever equations have been developed for estimating the GFR have been developed for non-cirrhotic population. But our population of cirrhosis is very different, because the serum creatinine may not be reliable. Again, these patients have ascites and portal hypertension and many other factors, sarcopenia, which leads to non-reliability. When you do cystatin C-based equations alone, the problem is most of the time the cystatin C is markedly elevated. So if you calculate the GFR is extremely low. So that ways you will be making your diagnosis of significant renal dysfunction in these patients. So when we looked at all the formulas which have been there in patients with cirrhosis, and there is another one formula that has been developed by one of our colleagues, the GRAIL equation, which they have developed from a very large their cohort of patients. So we found that it is the cystatin C and creatinine based CKD API equation that had the most reliability in making the diagnosis of the GFR in patients with cirrhosis. Now, this is another very interesting area, the urine microscopy. Now, when we see the urine microscopy, we are seeing the report that has been given to us by the pathologist. But when you see the urine microscopy report under the microscope, this is what you can see. These are 4 patients in the ICU. All of them required renal replacement therapy because of some indication or the other. But just look at the 4 phenotypes of kidney injury. So the HRS patient who had HRS NAKI and was requiring renal replacement had absolutely bland microscopy. There was some clumping of the tubule epithelial cells in this patient who had sepsis-related HRS. There were granular cast in patients with shock, ATN and ACLF, deeply jaundiced patient, and another patient who had severe ischemic injury. And the urine microscopy you can see is flooded with tubule epithelial cells. So urine microscopy is very different, even though your creatinine and your other surrogates, which you're looking at in the patients and you're doing dialysis, they may be absolutely different phenotypes. So when you're making a diagnosis, like we say for AKI, stage it with AKI grading, stage 1, 2, 3. Similarly, when we are making a diagnosis of CKD, it is important to make this diagnosis based on two assessments. One is the urine microscopy, the proteinuria assessment, the grade, that is the A1, A2, A3, and the stage. The stage is driven by the estimated GFR and the grade urine microscopy-based proteinuria assessment. But what we propose as a group is that we should also now classify CKD in patients with cirrhosis as structural and functional, so as to phenotype which CKD will recover with liver transplant alone versus a CKD which will require a simultaneous liver kidney transplant. So this is again very interesting. So again, rather than looking at different spectrum, we can just classify the acute kidney dysfunction as functional or structural, and we can start classifying the chronic kidney disease conundrum as functional and structural, and we can see that each one can evolve from one phase to the other. So these are just the etiologies, just to say that there can be multiple etiologies of structural in a same patient, multiple etiologies of acute. So kidney can be a very complex organ. So we have to look at the systemic factors, the disease-related factors, the factors which have led to the AKI. All these can help us understand what are we dealing with, and we should write a proper diagnosis and make efforts to understand the kidney dysfunction in these patients. And what we showed here was, again, very interesting. And this is the same cohort of 818 patients, where we showed that irrespective, so if the patient of the decompensated cirrhosis gets AKI, we can see here there is a rapid decline in GFR. Which is based on the concept that repeated AKI episodes is leading to driving the renal dysfunction. However, you can see here that irrespective of whether the AKI was there or not, even decompensated cirrhosis, so circulatory dysfunction, portal hypertension, can lead to slow decline in the renal functions. So this is another important thing, that portal hypertension itself is also a driver of renal damage in these patients. So chronic tubulointerstitial inflammation, which we demonstrated in this study itself using the cohort of antemortem and the postmortem kidney biopsies. And we highlighted this part in our cohort of patients that many patients had tubulointerstitial injury. Some also had coulommic nephropathy, which had ACLF phenotype. And these patients, therefore, need to be understood and managed, and where we want, because we cannot do kidney biopsies in patients who are sick. So here is where we need non-invasive biomarkers to understand whether we are dealing with a fibrotic phenotype of kidney or a functional phenotype, which is driven by portal hypertension. This is Paolo Angeli's group, where they showed that the acute kidney disease is something which, again, should not be forgotten and should be picked up in these patients, because acute kidney disease can evolve into chronic kidney disease. And what drives, so whenever we are seeing these outpatient stable decompensated cirrhosis, try and pick up acute kidney disease, because what factors will lead to the acute kidney disease is your mean arterial pressure. Apart from eGFR, age we know is one factor, and also the liver disease severity. So this is where the concept of mean arterial pressure becomes very important. Even if the patient is not admitted in your outpatient clinic, also start looking at the MAP levels and see that adequate renal perfusion is there and your patient is not having an acute kidney disease. Similar data, retrospective from Kavish and the group, has come from US, and they showed that acute kidney disease can actually lead in 1/3 of these patients to the development of chronic kidney disease and also worse outcomes. In the context of patients who are critically ill with organ dysfunctions or failure, we showed that if you look at the urine microscopy, the tubule epithelial cells, so we can see here the patient who had one granular cast versus the patient who had a full field urine microscopy. The patient who had one granular cast also had significant renal injury, but these were the patients who were recovering. And subsequent follow-up, we can see that there is clearing of the microscopy. And therefore, the renal tubule epithelial cells is because we should look into this. And Dr. Anupam had helped us by doing the very nice and elegant experiments in the lab to demonstrate what happens at the level of tubule epithelial cells. So it is the inflammation which drives the epithelial cell signaling. The mitochondria is very important in the renal tubule epithelial cells, and the mitochondrial dysfunction, increase in the autophagy, the vascular, so the vessels and the tubulointerstitial function, the vascular dysfunction is very important. And we showed that in this cohort of patients with cirrhosis, the MCP1 levels. So whenever we see a patient in the ICU or a critically ill patient with AKI, we see two phenotypes. Both may come with a creatinine of 3, but one will recover, one will not recover. We treat both the patients similarly. But it is now time to recognize at baseline itself that which is the patient who's not likely to recover. And this is where we should know at baseline what markers we need to do. So we showed that the patients were not recovering. They had a suppression of these genes of mitochondrial biogenesis. So if we can do the mitochondrial function and we can find out with some non-invasive biomarker that these are the patients you should be stratifying and you should be doing and treating them differently because they were not recovering. And these were the patients who led on to, and these patients all had increase in all the injury biomarkers and the repair biomarkers were suppressed. So same as the sepsis concept, the host response, the immune infiltration, the immune system, how is it driving your kidneys becomes important, because in the context of critically ill, the kidney is not revolving. It is driven by all other organs like shock, your hypoxia, your nephrotoxic drugs. Everything is driving kidney dysfunction in these patients. So we showed that the markers of vascular dysfunction, endothelin 1, von Willebrand factor, angiopoietin 2, and ADAMTS13, these were the markers of endothelial dysfunction. And inflammation, sepsis, renal vascular bed changes, everything means we should be targeting the endothelium in these patients, looking at these biomarkers, because these could be biomarkers which can tell us which patients are going to do well. And these were the biopsies from postmortem. Again, we've not done any antemortem studies on kidney biopsies. We saw that there was, again, in these ICU patients who died, there was increase in the collagen fibrosis markers, macrophage infiltration. There was hardly any neutrophil infiltration. So therefore, the phenotype, very quickly, these patients are going to fibrotic phenotype. And that is where, again, the decisions of selecting out patients for a kidney after liver or a liver simultaneous liver kidney transplant becomes important. So what are the factors? Hypoxia inducible factor is also something very important. And what we need to, again, there is a concept of tolerance. So same like Sareen sir has been talking about ACLF as the first presentation, a repeated episode of patient. So when we see two phenotypes in the ICU, we see patients who are decompensated, they are more likely to come out even with AKI or multi-organ failure. But a patient who have ACLF, based on the APASL definition, because the patient's body, the immune system is not tolerated to the immune insults. So multiple immune insults makes the organ tolerant. So if you are dealing, and that is where the debate with the nephrologist and hepatologist, because they are absolutely right. When they see patients with CKD, there is no need to rush on to go on to a dialysis. You can wait and you can observe. So the CKD will tolerate more insult. So when you're seeing patients of AKI on CKD in the ICU, rather than considering that they should be early considered for dialysis or other such therapies, it is better to wait in that set of patients. So that is where, again, this importance of immune tolerant mechanisms become relevant in the context of liver patients with kidney involvement. So we are trying to understand, but how do we make the diagnosis of acute AKI on CKD? How do we say what is the component of AKI? What is the component of CKD? So if we do not have the assessment of the baseline kidney health of the patient, it becomes absolutely impossible to say which component is driving what. However, if you have a baseline assessment of the kidney health, this distinction can be made very easily, because you know that you were dealing with this much level of kidney dysfunction, and this is the acute insult on the kidneys. So management. Now coming on to the management. So when I explained to you these two things, the tubular injury and the concept of chronic kidney disease. So as a group, we then went on to say that HRS should not be excluded in all such patients, and you should start diagnosing these patients in patients with cirrhosis. Forget about creatinine, assess the volume to make a distinction. And again, Ankur's paper on early initiation of terlipressin becomes very important, because it is not necessary that we wait for 48 hours. We can start upfront if a patient who has presented to us is euvolumic. And also, we need to exclude any changes which are there, which can be clearly due to a structural etiology or tubular dysfunction. So there's a retrospective series understanding the outcomes of, because people were treating, irrespective of whether the diagnosis was there or not, we were treating our patients who had CKD with terlipressin if required. And when they showed that the outcomes were not different with respect to the HRS outcomes, but what was different was the diagnosis of this CKD becomes important, because these patients have cardiopulmonary dysfunction, and therefore with terlipressin, there were more pulmonary complications. So it is relevant to make this diagnosis of CKD in these patients of HRS. In the context of ACLF also, when we see, these are the drivers. So when you see severe ACLF patients with very high creatinine, more chances of terlipressin-induced pulmonary complications. When the patient has reached a stage of respiratory failure in the ICU, where they are mechanically ventilated, where they are having severe circulatory dysfunction, background cardiac disease, we try and avoid terlipressin, because even though it is very effective, the risk of adverse events is very high. So we should be using point of care echocardiography, and this is Madhumita's work, where they showed that in the ICU setting, a hypodynamic or a cirrhotic cardiac dysfunction becomes extremely important, and we can use the non-invasive biomarkers like cystatin C and NT-proBNP in the critically ill set of patients, and along with the one-time echo measurement and understanding the cirrhotic cardiac dysfunction can tell us whether this patient is prone to recovery and also the development of complications. So specific management, very quickly, last 2-3 slides. So we know that this is how we should be treating, but when you're making this diagnosis of CKD, now we would like that we should be using the SGLT2, we can use Pendrenon, these are the next generation aldosterone antagonist, the serum albumin concept, long-term different dosing protocols, tips, again, identifying phenotypes of CKD to find the right population for tips where portal hypertension is driving the CKD phenotype. So this is something very important. Even in the ascites context, this data was presented in last year's ASLD. You can also phenotype ascites, whether you're dealing with a ascites which is vasodilatory phenotype, ascites in a patient who has kidney disease. For instance, we see many patients who have CKD and CLD and ascites or portal vein thrombosis, so vascular complications driving. So this becomes very important because it is a vasodilatory and synthetic phenotype of ascites population, which is not, which will require liver transplantation and will require TIPS, midodrine, all these strategies, while the other phenotypes may have, we need to have a different way to treat them. So maybe I'll stop here because the time. So tips I talked about, DAPA. We've done some work to show that DAPA can avoid the use of diuretics because diuretics are very harmful, particularly the loop diuretics for the kidneys. Mineralocorticoid receptor, that is the first choice drug which should be given in patients with cirrhosis. They're renoprotective and have multimodal effects. Finerenone is something which is upcoming. And again, we should look at the systemic effects because now we are knowing that liver disease is not just the liver, it is the systemic disease. So I would like to summarize by saying all these important key points: kidney health assessment, baseline GFR, urine analysis, renal imaging for all our patients with cirrhosis, understand AKD, CKD, all efforts should be made to limit the duration and severity of AKI, diagnosis of CKD in the extent of HRS AKI spectrum, point of care echo, stratifying functional and structural phenotypes, future holds for promising drugs like SGLT2 and Finerenone. And again, we need biomarkers for picking up the tubular injury and the fibrotic phenotype of kidneys. Thank you.
Ashok, thank you, Rakhi. We could have discussed more, but we have to go by the book.
Good morning, everybody. I will just take very less time because it's a little fascinating for you. So this is the digital twin, the emerging concept, how it's there. So I think this digital twin was first come from the concept from the NASA, where they simulate the lab, how the trajectory of the rocket is going to go, move and slide. And because of this, it comes to the industry 4.0, where the all industry before doing the building, they do a construction, how it is doing simulations, then go as we do the animal modeling in our case. And now it has gone to all sectors and the health has been not escaped. So now you can see here, this is moving the future. So what is digital twin? So this is a real twin. They match in most of the things because of the 100% genetic material. They have been influenced by the same environment, surroundings, outcomes, particularly monozygotic twins are likely same, even they can be transplanted without immunosuppression. And throughout the time, they have been modulated through the atmospheres. And the similar thing taken that can we make a virtual one? That is the digital twin. So what is happening? In that case, you take genomics, you take clinical history, get all the investigations, you put his all activities, wearables and sensors, track his activities, diets, monitor his environments, get his medications, get the results. So when you combine everything, you may not get the whole person, but to find the identical person who is merely tracked, monitored, and this is how the digital twin concept has come up. And this digital twin is commonly, we think of a product as we are thinking of, it can be a component of a person or the digit, what we're taking for the outcome letter, then a system, that is the in total, or it can be a process. You can see here the few examples I have given here. The product is a pacemaker, prosthetic valve, because now digital is mostly developed in the cardiac sciences. And so example is a pacemaker. So you have to personalize a pacemaker for a person. So how his heart rate, how it is going to behave the real-time simulations. So we have developed a product based upon the cardiac markers, how he is behaving, to simulate the naturally to maybe you have a digital, a healthy person comparison. See, each person is personalized because till now the pacemaker is that you have to calibrate each time. So it will get auto programmed. If this person is behaving this way, it will be monitored. The automatically program will give to feedbacks. So how it is coming up, then it will be more easier. If you think of a component like we have the Maselli digital twin, CKD digital twin. So now each individual is coming up with CK disease related that is can predict disease and how the treatments. The system is that a completely ICU automation. So if you come person is admitted to ICU, from the admission till discharge, you can make a model that this patient is likely to behave. So first 48 hours, you do the digital twin models, you know how they are going to behave in times. There's a process, there's the system. Then you use the process. Suppose like in ILBS, one patient comes to us on the day one for next 1 year, how is going to behave. We can track, we can monitor so that can guide for another 100 patients. So this is the how the digital twin is moving big way. And if you think of digital twin, how it is happened. So this is the what suggested that a person is here. He is reflected by his genetic, he is having the health, omics, environments, and patient reported outcomes and activities that and a diagnosis. You all combine, then you take help of this treatment strategy, his health trajectory predictions, then they can go for the virtual trials because on this will come later, and so that you can know the disease to go for early interventions. And how it is coming up will come see here. So for I have taken an example of liver disease. You think of, suppose someone is coming up, we can think of three ways. One is digital twin, in silico twin, and a virtual patient. They're nearly matching. So virtual patient is that you can see here, you develop a model artificially. Someone will come with 10 ascites, how he is behaving. If he has developed varicose hemorrhage, so you develop model, how you have treated, how the model can train another 100 patients to be treated. Hepatic encephalopathy, if he is diagnosed to be hepatic encephalopathy, so how your digital twin with a lot of gadgets can able to know this. Then in silico. So in silico is coming big way that you develop artificial cell cultures, you simulate the surroundings, develop the medication, know their side effects, and then you get wiser and you come now how it is has helped big in during COVID time for the drug discovery. So how it works, you can see here. First one, so you get the data. Real-time data is input from everyone. You get that is a level one. Then deductive. Then you from the all data, you find some model. Then this person, these are all known data. These are, now we are going for the retrospective or a prospective before validation. So we get all clinical data, laboratory data. We monitor them with all the wearable devices. Then we are giving the treatments. Then there is having environmental manipulations. And finally, you got a AI model for that patient. That is the AI model for that patient. Then comes the XML AI, that is agentic AI, that gives analysis of the person, how to go for the next level of interventions required. So level one is a cross-sectional model. It uses real-time health data to assess patient's current health. Then the second step is combining the current scenario, past data, so that you can able to predict the like you are doing acquisition aggregations, you can tell that his value is after 5 years. So this is how the second phase. 3, then simulations. So these persons get a real time. Someone is having like metal D. So if someone is getting alcohol, how he's going to behave as a fatty liver wise. That's the environmental modulations. Then lifestyle and environmental factors. And last comes the analytics, which comes into the play for the interventions. So what happens? You can see here very interestingly, here this very picture quality is very poor in this computer. So I'm sharing the wearables devices, all are there. The all data goes to the deep learning model, then comes the outcomes. So how to get this? This data goes to the AI. Yeah. And data can be secured different ways, cloud, blockchain, IoT is the sensor-based things, then explainable AIs, and all combines to develops this big data, algorithms, then training of the model, then you get an user interface, then you get analytic results. These results has been modulated by your training cohort. They give the instructions and the cycle goes on. This is called as CDSS, Clinical Decision Support System. So once you get the inputs, you know the outcome, you monitor, you guide the treatment suggestions. So how it is moving on, because for difficult for a medical person to know the details integrity. I have just covered how these things are going on. The real coding is different way. So I want to see how it is helping in our day-to-day practice. You can see here, if you think of having a digital twin, it can help in patient-specific models. We are covering hospital clinical operation, predictions, prevention, medical device testing and developments. Then insurance operations, now it is coming up, personalized wellness treatments. And like all now big data is going to the public health, population health management, emergency response planning, research development, telemedicine, this all way coming up that way. And with the where the science is moving on digital twin, you can see here this is a meta-analysis of 40 digital twins available in the world in last 2024. So here the maximum is for the heart. You can say it is for the vascular is 10%. And rest are and lung is because of the X-ray and digitals. And liver is only one. I will cover that the MASLD model. How the digital twin is helping for the disease. So now the liver area is a big and untouched area for the digital twin modeling. So how it helps if you go for it identify the risk stratify, operational optimization, predictive analytics, engage the patients. Most importantly, when CDSS is there, you get continuously engaged like what you are seeing the AI for the all social media, you can get engaged to your own health related events. And home digital technology now it is coming that you can monitor the patient from the home, particularly the senior living, and fraud detection, be in the insurance, be in the medicals. And this will help in reduce processing time. This will improve accuracy. Lot of cost savings will come and enhances experience of the patient as per treatment concept. They remain continuously engaged and have a good scalability and strategy expansion mode. So if you think of how this has gone to the basic research, so this is what you can see here. The initially it is the animal model. What we do, develop an animal, we give intervention, get the outcomes. But now all this is come as a NAM. This is the FDA term, that is newer approach methodologies. So now they have taken the all simulations in doing are no more called as the and because not involving traditional way. So what is they develop? Suppose a human cell or organoids, a liver on chip. You can see multi-opic computational models. So this is where you do in the labs, simulate them, disease condition, give interventions, get the outcomes. And this new approach models has come to the what we are using, they call it PDT, that is patient digital twin. That is ये क्या हो रहा है? हाँ, so patient digital twin. So here what we have discussed is the patient digital twin because digital twin is all into aspect. Then patient biomimetic twin. That it means here you take the biospecimen, develop in culture, give the surroundings that will comes up. And the next is the integrated one. When you use the PDT, that is patient digital twin with biomimetic twins. It is the vital. So you can develop a fatty liver model in your lab, give them simulations, get the outcomes, then the results can be utilized to the clinical setting. So this is an interesting one they develop, and this digital twin called is not animal, they called as the MPS, microphysiological system. What they have done, they've taken the cells as make the iPSCs. These iPSCs are simulated to develop different type cells, hepatocytes, cholangiocytes, endothelial stellate cells. So all these cells are get stimulated to who is going to develop. This is a NAS model, is Jaydeep Behari is the author. And there is a seminal liver disease last year paper. Very interesting. So on that, you can clone all cells in the lab. You give the exposure to the fatty diet. You see how which cell is getting more active for the fibrosis, which is developing steatosis, which is responsible for the cancer. So you know the trajectory so that you can help for the interventions. And how this MPSC works, you can see here. You can take albumin secretion, urea secretion, LDS release, steatosis, pro-inflammatory cytokine release, stellate cell activations, pro-collagens. So all these can be studied in a cell in a simulated atmosphere to know how this is behaving. So this is how it makes the precision model. What you develop, patient-derived cells and organoids, you give the surrounding simulations, and then what is happening here? So this is a coming of the way. This is abstract. So this is organ on chip. So organ on chip is still now, it is all on the labs with the wet lab, but now it has come to the dry lab wet. You can see here. So DigiLock is a software. They have developed a tool where the complex mechanisms are being simulated. and this gives how the drugs is releasing. Very interestingly, you can see here. So this is where they have taken the cells, they have been exposed to the drugs, and their clearance is established. So it is conventional. You can see the curve, and you can see here the digilog is how behaving. क्या हो रहा है? नहीं, मैं तो टॉस नहीं कर रहा हूँ. And this is the difference you can see here. This is the actual one. So here it is the represent what we do for the clearance, which is nearly 3 times highly predictive, and this is the trend from the digital twin, and these are different time points. That shows that you can get drug clearances. So ma'am, they have developed cells which are using the cell. Suppose the lot of drugs have forgot the diclofenac, all they have taken the hepatocyte cells into a lab on chip. They have given the drug exposure. They find the clearance for the different pathways. So this pathway are simulated from the predictive analysis as per the product is releasing from the cells. Then see that suppose it is the diclofenac, how it is getting peak, how it is going down. So then when I've seen 3 or 4 patients, they develop model how to predict. Then at the same time,
Organ on a chip is a 10-layer, 15-layer with normal perfusion, the way you have perfusion. So the organ on chip is like a mini liver, mini lung, mini kidney. And in that, drug testing is the standard now. This is the way drug testing is done on multi-layered.
So what we were doing up till now was not as effective as what we do now.
no, they're on a comparison only that key the drug clearances level what we are estimating from the lab is nearly 3 times overestimating. If they are taken from the 5 and 6, because simulated atmospheres, they are able to predict. Suppose they are not doing for all. So they have done for 50, they develop a model, they can know the predictions as per the individual cell line wise, organ wise. So this is how they tell you that it is nearly accurate to the 1.2 to 1.5 times overestimating. And this is very interesting one. This is the repurposed indications, how they got it. The whole COVID, the drugs, even the current user resmetirom, these are drugs come from the AI. That first you go to the drugs, see their mechanism of actions, then you see the disease, see the pathophysiology, then you combine both. Which mechanism of pathway, which drug is working. So from the available drugs mechanisms, you can find a drug. So this has been bigly used in the COVID and also for the resmetirom for the NAS way. And so you can see here the whole genome has been decoded. We have all the data, and that is now come up is the large language model wise you develop a database. From the database, you can find the peoples, you can find the markers to get the results that can be used into the genomic integrations. So this is basic. Now we'll show the how clinical utilized. So most common is the cardiovascular care. So if you are having a atrial fibrillation, the next atrial fibrillation is going to happen when you can get alerts. So you have taken signals, you've taken imagings, you take genomics, you get all parameters have taken. This has been analyzed and get real-time data. Suppose you have get heart rate fluctuations, the immediately system alarms to the doctor and to the clinician. So and to the patient itself also. Then both can be active to get a healthcare facility to be done. And this is what he suggests that this is the problem. You have to go for this. So in that what they have taken all electrophysiology parameters they have taken, electromechanical, how the blood flow, that is fluid dynamics, and then all cardiac activities simulated in the labs. These are all integrated to get a model. Then this model is going to the ChatGPT generative AI, these large language models. This gives the output. This outputs guides that your disease is problematic. You take help or become alert. Similarly, it has come big way to the diabetes. So diabetes is now revolutionary with use of CGM, that is a continuous glucose sensor. You have taken smart scale weighing wearables for the activities. You have taken the dietary feedback interventions, blood and lab duties. Then you make a completely individual database. And this has been taken to the person concerned person. Is this patient have a phenotype, something that is diabetes will fluctuation, his disease condition is this way, his physical activity is different, his diet is different. And then you develop this person a specific model. And this model will guide you that your sugar is high, you are going to avoid this food, you have to go for this much exercise, everything in the real world can this. And this has given lot of product has come up. I think this is very poor I don't know, my laptop is showing good here. Similarly, the cancer, the similar way, I'm not taking more time. The cancer has also revolved the similar way. You take the whole genomic profiles and come up. So I'll go basically, that is a radiogenomics. So what they have developed now for the cancer care, you get a radiology. You know, there are some genetic variants may respond, may not respond. So how will you go for medical images, develop radiomics, get their genomics, radio and genomics intervention can say which person is going to have it. You can get a diagnosis, you can get a likely model who can respond, which may not likely to respond. And this is the trials are going on the radiomics and integration of radiogenomics for the SCC to be treated. And similarly, the pathology has come up big way, very poor. This system is outdated. Poor for the now you can predict. Suppose you have a cirrhosis, you go for the histology. It is कहाँ है मतलब टच ही नहीं करे कैसे हो रहा digital models to develop. So this is a retrospective validation. We have all patients having SCC, their liver biopsy, non-tumor biopsy. So these biopsies has correlated this 5-year have old biopsy. So they're able to correlate that this is the histological pattern. This is the disease. You can get a SCC likely prediction. Similarly, now it has moved into the intervention area. So TARE, the SIT is a big way. What happens with this digital twin? You get the anatomy, you know the blood flow, you know the vessels, you know the angulations. And by modulations, they are able to know which way the arterial catheter will go. And you can see here, and this arterial catheter will be able to get a fluid dynamics monitor from your end. So that the TheraSpheres moves accordingly. They deposit at the different point area. This is all can be controlled by the equations in the lab. And this is how they are able to tell that the tumor response you can predict. You can tell with accuracy that the SIT is going to be happening, adequate or no, by the simple lab models of the digital twin. Similarly, this comes for the microwave ablation. For the SCC, you first get the imaging MRI, you do the segmentation, see the tumor. Then once the tumor, you see the vascular anatomy. Then in lab, you simulate with a probe virtually whether your probe is going to cover 3 centimeter area, 4 centimeter area, or the needle probe should be 900 or 1500 needle. And then you predict if I go for small needle, I may escape this much of area. Or if I go for a bigger needle, or this is the angulation, I can get maximum area coverage. So before going for this in lab, you can do all automations from your end so that you can be done the MW. So this is a very futuristic and this helps minimizing the clinical expertise where anyone through a modulated flow can go for MW with a good accuracy. So this is how the world is moving for the way. Then now come to the liver area post-transplant. You care. This is basically for the kidney data. This one that you get the trajectory, get the parameters, get the recording of 100 patients for 1 year. You can predict what will likely the TAC level for this patient. So that means if you are able to know that likely TAC level this patient is going to be these variations, you can ensure them how to go for. Similarly, you get the data, you know the people who are having high risk for developing rejections. You know the TAC level variations, and for the data, you know the parameters. And this model has shown accuracy that you can combine to know this patient's likely to develop a rejection. And most important is the cardiovascular events of the transplant. It is the most common cause of mortality after 2 years. You get all parameters like age, diabetes, creatinine, and if he is having a NAS-related cirrhosis, right ventricular systolic pressure high.
Shah has already talked to us about. These are the same.
No. It is not total. He's shown the basics. This is the application.
This last slide.
No, these are all ma'am applications. He's told is the technology. I'm telling those applications only. So what I'm telling that you can predict the diabetes. So all this means I am just this is a piece. If you combine all the things, the whole transplant can be in a digital twin. Your patient get transplanted. You take his pre-transplant parameters of everything, then get the donor details, whatever is there, cadaver life. Get क्या हो रहा है? Then get the yearly post-transplant events, the immunosuppressions, and long-term surveillances. From this, you can get a trend that how your patient is getting monitored, and this way will help in bigger way to reduce the incidence of complications, rejections, poor compliances, and helpful. So just to now, what is food pathology is the fatty liver. You can see here fatty liver in imaging, you can get a surrogate. From MRI, you can get nearly steatosis, fibrosis involvements. I'm going quickly. And then digital pathology. Digital pathology is nearly accurate to tell what are the cells and how it is happening. And this is a morphoquant. This develops that can everything, the whole slide image scanner. You get fibrosis, you get steatosis, you get inflammation, you can everything get from this. So when you get from the imaging, you get from a surrogate from the digital pathology, and you utilize this. So how you combine this, you can get screening for at-risk patients, risk stratification, disease staging, prediction of the disease progressions you can do in a longitudinal follow-up, prediction of extrahepatic complex, which is big area untouched, and prediction of therapy, what you have given, and therapy related toxicities if you are giving. So this is all you can go in a long term with the use of digital twin. So this is one of the studies where I have done digital twinning for the fatty liver. They talk wearables, sensors, lab parameters, clinical follow-ups, nutrition, ARVR has taken. So all this data has been combined to get the output that fatty liver should come up. So this is what called the digital assisted muscle interventions. What they have done, they have taken all the parameters, particularly diagnosis, then their data has been collected, they have been engaged through the technology, and their information has been taken up. So every 6 months, they have a monitored for the all parameters. They found their weight loss is happening. There is physical activity is getting more robust, nutrition is getting better, and this leads to the significant reduction. And what they have taken here, personalized nutrition, lifestyle recommendations with nudges that just our mobile everyone will getting your sitting is more that way. Then CGM activities and activities. This leads, you can see here the traditional versus digital way. The fatty liver reduction has significant visceral, subcutaneous, and abdominal fat, liver fat. So all reductions has been significant because fatty liver is a disease of lifestyle that can be reinforced. So just to go, so these are the available different digital twins, and across the disease you can see here till now diabetes is one for us, heart is more robust way, and lung is to some, and hospital automation. These are coming the digital twins in healthcare. And these are the centers you can see here. The one is Sweden, then is one basically two from Sweden, one later Netherlands, and US and Taiwan is coming up with the digital twins come up for disease particularly related. So this is what we can see here. There's a health related digital twins coming up. These are few limited online support systems for the digital twin. So how it is going on? This is a big way going to suit up. And if you go for the futuristic way, the drug development, personal medicine, surgical planning, these three are going to be revolutionized by the use of digital technology. Who are going to be major users? The pharma and biopharma, research institutions, and providers. So this is the prediction. So with this, I want to say that what we can do, this is the future. Healthy, unhealthy asymptomatics, or unhealthy symptomatics. This is what the digital tool can make a one-line solution. Thank you.
Give one example. We have a patient who is waitlisted for transplant and has an HCC. With the nature communication by Mamta, you might have heard. And now there is another patient with same digital and has an HCC. This patient has progression, whether he will develop unresectable HCC in 3 months, 6 months, 9 months. And the other guy, when is he likely to develop progression? Second, he has a donor, whether this donor will fit this recipient or not, also is being used by the digital twin. I think what we have opened up is a new area, and we should work on it, and maybe we should regards and other system. Any other comments? But in the interest of time, Isha, are you here? Maybe you also can pitch in, and at least one area we should pick up, if not, and see whether we can do that. System pathologists are here.
I thought we were going to do some more
Yeah.
hands-on
Ma'am,
with the Isha so
exam-
that we learn more.
Yes,
But
ma'am.
just taking up these topics like you've taken it today.
Should have something.